Thank you, Professor Roskam. It's a pleasure to be here with you all. And I'll try to share my screen. First of all, okay, I think that now you can see my screen. And
thank you.
Okay. Thank you. And I'm a hepatobiliary surgeon. Yes, I do work in Milan. I work in San Raffaele Hospital, which is directed for the hepatobiliary part from Luca Aldrighetti, Professor Aldrighetti, and it is my pleasure to represent our view on what in surgery has the potential to affect the current guidelines for HCC and cholangiocarcinoma, which is mainly, as you probably can at least in part imagine, the minimally invasive approaches to hepatobiliary resections. This is something that we have pioneered and that is actually current standard part of our activity. You can see that our activity in laparoscopy for liver resection started in 2005 and had a gradual progressive increase because of the results that we have obtained with this. And now in the last year we have reached nearly the 65% of our annual resections which are done by minimally invasive approach. If we compare this data to the 2005, so to the beginning data where this ratio was the 5%, you can see how much increase in this technique we had. And by minimal invasive approaches, what we intend is pure laparoscopic resections, which is the most classical part, but also a program of robotic resections, which started last year in 2021. Of course, our massive experience is in pure laparoscopy at the moment still, and as you can see in the left part of the slide, we had gained progressive experience to encompass in our activity all kinds of resection. That means not only minor and major resections, which is the classical difference, but also different kind of resection, and especially what we call complex resection that includes also resections in cirrhotic patients. You see that on our global experience and the case history, which is about 4,000 resections so far, the big part is constituted by resection for colorectal metastases, followed immediately by HCC and cholangiocarcinoma, which in total make nearly the 45% of our activity, so a real big part. And in the right part of the screen, you see what is the proportion in terms of diagnosis as far as what concerns only the minimal invasive series. So HCC gains the first place, accounting for the 36% of resection, followed by metastasis, and cholangiocarcinoma remains to the third place with nearly 20% of resection. So why this? Because HCC, first of all, is the most classical indication to minimally invasive approaches, not only, of course, in our experience and series, but as you can see here, this is the same data that we gain from an international, a world series of some years ago, and also from an Italian snapshot of the situations and the indications to minimally invasive liver resection. So HCC is the big part. Why? Because HCC, as we know, arises in the majority of cases in a cirrhotic liver, and we will see later on which are the basis of the clinical advantages that appear clearly from this table with respect to the open approach. These are the conjoint data of 3 meta-analyses which have compared the results of open versus pure laparoscopic liver resection for HCC, and you can see that we don't have any red spot, so we don't have any data that favors open, but we have some equality, and then we have also some advantages of laparoscopy on traditional laparotomic approaches, especially in terms of blood loss and consequently transfusion rate, and in the postoperative course in terms of morbidity and length of stay. Based on this data, which have been collected during the years, we arrived in 2017 to the first consensus guidelines on laparoscopic liver surgery, which produced practical recommendation. And you can see here that the recommendation for hepatocellular carcinoma are more than one. And especially I would like to highlight that the laparoscopic approach was found to be the only independent factor to reduce the complication rate in minor resections. So we have advantages for patients, but which are the basis for this improved outcome, and which can be the outcomes in patients with HCC advanced disease. The basis for improved outcome are, first of all, and what is more frequently reported reason is the lack of interruption of wall portosystemic shunts that we indeed have in laparotomic surgery, and the absence of need to extensively mobilize the liver to conduct the liver resection. This is a study which applies also to HCC patients. We have compared what is the clinical advantage of laparoscopic resections compared to open. As for what concerns the most easy and straightforward localization of the lesions and consequently the resection compared to the most difficult resections, which are the resection on the posterior superior segments, which are protected by the ribs. And surprisingly, what we found is that the difference in advantage with respect to the open approach was much higher for these difficult resections than for the easier resection. And this applies also to HCC patients, which constituted a big part of this casuistry, because we can avoid to mobilize the liver, and we can thus preserve the hydrological balance of the patient. But also there is margin to imagine that this is not the only reason, but as it was proved already for colorectal liver metastasis in a very important and famous randomized controlled trial of laparoscopic versus open, there is also a biological impact of laparoscopy, which can favor the outcome of the patient, because the surgery is globally less invasive and the biological influence on all the organism is more well preserved. In this study, that was proved with the determination of values of some inflammatory markers and cytokines, and the results are very interesting. We don't have data especially for HCC, but there are some other studies which prove the same in the clinical setting. And what are or can be the outcome in patients with advanced disease? Because we know that HCC patients are a very heterogeneous population, and there are some very clear and classical indications to surgery, which are very clearly stated by the guidelines and especially by the BCLC scheme. But there is a huge part of patients which cannot, which is not classically allocated to surgery because of some risks that we all well know, and this patient unfortunately can undergo only a second line treatment. So what we have started to study is reported in this study of which is quite recent, where we had the aim to analyze the outcome of laparoscopy, especially in patients with intermediate stage HCC, and to define what is the differential benefit compared to patients with the early BCLC stage. We enrolled nearly 600 patients. These were the two groups of comparison. And what we found was that the laparoscopic approach had a statistically significant advantage in terms of blood loss, morbidity, and hepatic decompensation, and shorter time for functional recovery and length of stay, which was greater for intermediate than to early BCLC. So this is the second part of the study, where we examined the differential benefit, which was, as you can see, much higher and greater for intermediate than for early stage patients, especially for blood loss and for the morbidity rate. So the most important message for this study was that the favorable biological scenario, which is associated with minimal invasiveness, allows to obtain some benefits which are enhanced in the setting of more advanced liver disease. And this was another study which we conducted as a multicentric study, and we compared all patients operated by minimal invasive approach for HCC. And first of all, we found that there were similar, not different outcomes, both intraoperatively and postoperatively, between child A and child B patients, which we know that have very different degree of liver disease, and the child B patients, of course, can be much more critical to manage with surgery. So the equality of these results let us say that probably laparoscopy can preserve some of the safety of the resections, also in patients with a liver function that might be critical. And also interesting in this study was that severe comorbidities and the conversion to open approach were found out to be as risk factors for major complications in the postoperative course, but were not risk factors the severity of the cirrhosis and the presence of portal hypertension. So this is a very important study that let us ask a question. So how to maintain an adequate profile of safety if these are the results that we can achieve by laparoscopy in HCC? It is certainly the case to establish a proper and accurate patient selection and surgical planning. So before considering a patient for surgery, we should take into account the surgical criteria. We cannot pass on the extent of resection, the depth of the lesion, and, for example, the need for extensive mobilization or risk of wall shunt discontinuation. And we also have to take into account functional criteria, and we know that there are different methods to do that. The same criteria which are adopted in open surgery should be taken into account, but with a wider range of inclusion, but we should also always consider the risk of conversion to open. So the higher can be for the patient the risk of conversion, and the lower should be the range of inclusion for critical patients. And here we have some videos which are running, which regard the surgical planning. So we know that anatomical resection are the mainstay for the treatment of HCC, and for sure we have to apply them in case of the lesion is located in a clear laparoscopic segment. In case we have the risk of unclear margin, we know there is satellitosis, and we don't have any previous episode of hepatic decompensation, but also we can consider non-anatomical resection, so more conservative surgery, in case the lesion is located in difficult, so the so-called non-laparoscopic segments, if we have a capsulated lesion without satellitosis, and if the patient has had some previous episode of hepatic decompensation, which we have to take into account as far as concerns the risk of postoperative liver failure and ascites. It is also very important the anesthesiological management during the operation, and we found very useful, as we published in the study, the hemodynamic control with using the stroke volume variation parameter instead of the more classical central venous pressure control, which allowed us to reduce the conversions specifically for hemorrhage and to reduce the blood losses during the liver resection. And also, it is very important, according to our experience, the perioperative management of these patients. We know that the last 15 years have been in surgery characterized by an implementation of the so-called fast-tracked programs of perioperative management in different types of surgery. We found that this is applicable and worth to be applied also in liver surgery, and that the results of a fast-track program in addition to a laparoscopic approach further enhance the already proved advantages of a fast-track management, which is applied to an open resection. So basically, patients which are approached by laparoscopy and management within an ERAS protocol have the better results, and HCC patients, as we have found in this study, are a very optimal category of patients which can benefit most of these approaches, because they can have enhanced benefits with respect to other type of surgery, of liver surgery for other categories. So my message is, I suppose, for what concerns HCC, is that the laparoscopic approach has documented since its beginning some benefits over the open technique in terms of especially reduced blood loss, transfusion requirement, and complication rate. And the basis of this advantage still has to be investigated specifically even further in the setting of HCC, but there is strongly a potential role of the favorable biological scenario that can be speculated in addition to the preservation of wall portosystemic shunts and integrity of the abdominal wall. Disadvantages are evident even in the subset of patients with more advanced disease or with impaired liver function, and in particular in child B patients, laparoscopic approach seems to reduce the biological impact of surgery and therefore allow to widen surgical indication. And we have already said how to optimize the results of the patient, that is a preoperative strategy and intraoperative adequate management are needed in addition to a fast track perioperative program, which is indeed much warranted. For cholangiocarcinoma, the situation, the state of the art is different. It's different because, as we can see here from the same guidelines on laparoscopic liver resection, which were held in 2017, at that time, which is only 5 years ago, differently from HCC, there was no strong evidence yet and to support and to give strong recommendations regarding laparoscopy and minimal invasiveness in general for intrahepatic and perihilar cholangio. You can see here we have reported two meta-analyses, one on hilar cholangiocarcinoma and the other on intrahepatic cholangiocarcinoma surgery approached by laparoscopy, and these are recent meta-analyses, and the data on which these meta-analyses are based are all very recent studies, which are available most from 2015 onwards and regard small number of patients. So this is still one of the spaces where laparoscopy has to gain much experience and much evidence. But why laparoscopy came so late in the minimal invasive liver resection? Because especially because there are several technical challenges in the feasibility and reproducibility of this procedure. First of all, we have major hepatectomies required in the most of the cases to control biliary and vascular involvement for the disease, the need for a lymphadenectomy, which is recommended for the staging of the disease and likely has also a prognostic value. Segment 1 resection, which is a difficult part of liver surgery, is mandatory to prevent local recurrence in perihilar disease. And also there is the issue of biliary confluence resection and reconstruction, which is the main challenge, both in the phase of demolition and then also in the phase of reconstruction. So what is happening is that several groups are doing researches specifically on this technique for this disease. As you can see in this slide, this was a patient with a perihilar cholangiocarcinoma elected to a left hepatectomy, which we approached by laparoscopy, and we had also gained some experience and technical insights on how to conduct after having gained experience of laparoscopy in other type of liver disease, also oncologically radical and efficient postoperative course for patient. You see here that this is the first phase of the operation, which has started with the lymphadenectomy, and this is the skeletonization of the hilar the hilum. So we have to deal with the vessels, we have to deal with the main bile duct, and then we have to conduct a major surgery, which also involves the segment 1 resection. I'm not going to show you all this video, but you can see here that we are dealing with segment 1. The space is very narrow, so it is a difficult part of the operation, and we are working near the vena cava, so we have to be very careful, but we cannot forget that this step is essential to ensure oncological radicality. We have to take care of possible additional or vascular anomalies for each patient. So the preoperative staging is fundamental. And here you can see the transaction phase as for what concerns the liver parenchyma, which falls onto the hilar plate. And here the bile duct is open. So this was just to give you an example on which different steps are needed to conduct this kind of surgery, and which experience the surgeon has to have gained on each step. And so this is one of the last phase of laparoscopic liver surgery that is recommended to approach to liver surgeons. So when they have already acquired experience with lymphadenectomy, major hepatectomies, and resection, which are difficult on the posterior superior segments. We found much advantages for what concern minimal invasiveness for the robotic approach, thanks to the dexterity of the movement of the instrument, and thanks to this, we can also approach the reconstructive phase more easy than with pure laparoscopy. With this paper, I just want to stress the importance of an adequate lymphadenectomy, which was one of the main criticism moved from the surgical and oncological point of view towards this kind of minimally invasive surgery for cholangiocarcinoma. Of course, the lymphadenectomy should be as complete as open, and should involve station 8, station 12, and in some cases, when appropriate, also station 13. And here also there are some images of a segment 1 resection, which has been approached for perihilar cholangiocarcinoma, and is also an important part of the operation, which have to be conducted extremely safety. So some technical tips and tricks on the approach to the paracardial liver segments are needed before embarking in this kind of resections. As for what concerns the biliary confluence resection and reconstruction, this is not yet a standardized technique, and still reserved hence to experienced centers. So there is a need to be standardized before being implemented in the standard clinical practice. This is another video which we enjoyed very much to produce, because it was a technical specific insight on what can be the tips and tricks and which are useful to reconstruct by minimal invasiveness the biliointestinal continuity. And again, the robotic surgery plays a huge part for this kind of surgery in the panorama of the minimal invasiveness, thanks to the improved dexterity of the instruments. Which are the advantages of minimal invasiveness for cholangiocarcinoma. We can have lower blood loss and rate of transfusion. We can have shorter length of stay and interval within adjuvant chemotherapy and reduce the incidence of complication. And the side, we can have also lower mortality and the trend towards the increased achievement of textbook outcomes. There is some warrants about the possibility to yield an adequate number of lymph nodes and or again as a lower incidence of lymphadenectomy, which has emerged by some studies. But we have to say that we need to interpret the data very carefully, because the data that we have now, most come from small series which have different case mix. And we know that especially hilar cholangiocarcinoma has a very different case presentation. Series had a very different hospital case load and surgical expertise. So the evolution of standards on laparoscopy and consequently on the recommendation needs yet to be based on more careful data. What we have found in our experience in this study, which is a monocentric study and included a quite large number of patients compared to previously published study, was that the time for lymphadenectomy approached in minimal invasiveness was not different to open, and also the number of harvested lymph nodes. So there is the margin to apply minimal invasiveness to adequate lymphadenectomy. And also we can have a reduction in lymphadenectomy related morbidity. So oncologically speaking, a radicality preserved and also some clinical advantages for the patients. In this study, we have focused the analysis on the oncological outcomes of laparoscopic surgery for intrahepatic cholangiocarcinoma operated at our institution. And we found no difference in the comparison between laparoscopy and open in terms of median disease-free and overall survival. Instead, this is a study on long-term outcomes, and we see here that minimal invasive approach can also positively affect the disease-free and the overall survival of cholangiocarcinoma, which have a greater risk of recurrence with respect to those that have an intermediate or a low risk on recurrence. And this might be, this is reasonably related what we found to an earlier return to adjuvant treatments compared with open, thanks to the minimal invasive advantages in the recovery of patients, and also to a possible positive impact of a reduced biological stress. This is instead a focus on what we know now about the long-term outcomes of minimally invasive surgery for perihilar cholangiocarcinoma. We only have preliminary data, and we can only say that minimally invasive surgery appears both surgically and oncologically adequate and safe. Also for perihilar cholangiocarcinoma, but only in selected patients and if performed in presence of acquired experience in minimal invasive hepatobiliary surgery. So I will leave you with the key messages on cholangiocarcinoma, which is that the minimal invasive approach for both intrahepatic and perihilar has experienced a later diffusion compared with other frequent indication in MILS series, especially for HCC. And the reason of this delay are related mainly to the technical challenges of the procedure and to diverging evidence in the literature. Technical challenges are associated with the frequent need of major hepatectomy, requirement of formal nodal dissection, resection of segment 1 in perihilar, and eventual need for biliary and vascular reconstruction. With inappropriate indication, the feasibility and reproducibility are reported and are feasible, but also concerns regarding the oncological adequacy for these procedures has been reported, in particular as for what concerns lymphadenectomy and its adequacy, which can possibly jeopardize the oncological results. So it is important to stress that the oncological principles of surgery for cholangiocarcinoma, as for any other oncological disease, must be followed irrespectively of the approach which is adopted. And the robotic surgery, thanks to the improved dexterity, may provide a further advance in the diffusion of minimal invasive liver surgery for intrahepatic cholangiocarcinoma and especially for perihilar cholangiocarcinoma. And I will thank you for your attention.
Thank you very much, Federica. It's extremely impressive, but I think the main message must be here that you need a lot of expertise before you just go on for robotic surgery. So it must be, I think, really kept for really specialized centers in these techniques, no?
Yes, yes. This is the main message. Liver surgery is one of the latter surgery where minimal invasive came. So this is because indications are very wide. And technically resections are all difficult surgery. Robotic can help and can help much, especially in the difficult areas where pure laparoscopy struggles to arrive. So now we have an experience which encompasses very different types of resection, and what our experience tells us is that robotic, which is probably the natural evolution of minimal invasive anyway, will help minimal invasive to further expand the pool of candidates to a safe surgery, to improve postoperative outcomes, which we have seen what can be the results in HCC, the repercussion in HCC and in cholangiocarcinoma, and so to allow most patients to have a safe surgery.